Next up, we have Dr. Marcus Tan, who is the Chief of the Department of Recovery Care at IMH, as well as a Senior Consultant Psychiatrist with a special interest in geriatric mental health. Dr. Tan will be talking with us about a very ethically fraught case, a topic that could be the subject of its own whole conference, and maybe will be, covert medication. Dr. Tan.
First of all, very good afternoon to distinguished guests and colleagues. A lot of familiar faces here, seniors, other mental health professionals, and also a lot of my friends from the hospital are also here. So, yeah, very excited to be giving this talk about covert medications, right? Okay, so I don't have any slides, so you have to listen to me. Sorry about that. Yeah, I'll try to make this painless. Yeah. Okay, so when I was first asked to give a talk about covert medications, right, my first thought was, why was this topic parked under the mental health segment, right? I don't know why. Is it because mental health professionals are particularly prone to this practice? Is psychiatry that notorious for such practices and other practices? Is this practice limited to patients with mental health issues only? Okay, I think these are pertinent questions to consider. Yeah. Perhaps it's a legacy issue because psychiatry is quite a malign kind of discipline. A lot of anecdotes of coercive treatments that are not evidence-based, barbaric, inhumane. So I'll leave you to a lot of I don't have any clear answers to this topic, but I just hope to have you guys think a little bit more about some of the issues that we faced and maybe come to your own conclusions as to whether or not it is a moral hazard or an ethical choice. Now, first of all, definitions. So covert medications means you administer medications that have been disguised in some form, usually in food or drink, so that the person doesn't recognize that they are taking the medicine. Okay? There haven't been many studies about covert medications. There are, but not many. But whatever that's available suggests that it is a fairly common practice all over the world. Certain settings are predisposed to covert medications, long-term care facilities, for example. Certain patient groups are more prone to be subject to such practices. Unfortunately, those who are legally detained, those without mental capacity. And most unfortunately, a lot of the medications that are involved are psychiatric type medications. So maybe that's why this was parked here. Also, that's why I bring my own water. Yeah, just in case. Yeah. Paranoia, yeah. Hey, don't, it's important, okay? Yeah. You have a lot of mental health people, like, swimming guys around you. Okay, now, the interesting thing about covert medications, a lot of these practices frequently go undocumented, and hence it's very poorly regulated. There are a lot of common reasons in the literature why covert medications are given: prevention of harm, especially if there's a history of serious harm, medications preventing relapse, etc. I mean, you can read all about this in the literature, so I won't go too much into it. Now, Dr. Giles mentioned coercive treatments, okay? Which essentially means you treat a person against his will, in spite of his or her opposition, okay? When we give covert medications, mostly the patient doesn't want to take medications. Essentially, covert medications is a form of coercive treatment. Agree? Yeah. It's a little bit more tricky because coercive treatments can be formal coercive treatments. I restrain you, I put you in a room, I seclude you. Or, psychiatrists are very good at this, we informally coerce patients. For example, if you take your medicine, you let your wife supervise you, then I let you go home. You know? So I hear myself saying that sometimes. Is that persuasion? Is that negotiation? Is that informal coercion? That remains to be decided. But the point I'm trying to make is sometimes the line is very, very unclear. Now, Coercive treatments, covert medications, infringe on several fundamental rights: autonomy, beneficence, non-maleficence. When we decide to covertly administer medications or coercively treat a patient, we give weight to other principles, right? Duty to community rights, duty towards others, etc. All right? There's no clear-cut way to determine which principles should take precedence, and oftentimes in our daily work, we find ourselves navigating this tug of war between all these various principles before finally deciding which one overrides one or the other. Okay? A lot of talk, a lot of time has been dedicated to decision-making capacity. Dr. Giles alluded to autonomy. Interestingly enough, there's a bit of a difference between autonomous and having decision-making capacity. A person with decision-making capacity may not be autonomous. But in Singapore, we have very clearly articulated in the Mental Capacity Act how to establish decision-making capacity. Across the world, across the various legislations, you will find some laws or other that articulates how to assess decision-making capacity. They're all what you call same but different. The language actually is very nuanced and very specific. What do you mean by appreciating? What do you mean by weighing? What do you mean by understanding? So it's actually quite interesting if you look at how the various countries, work. Okay? And obviously, because a lot of us are medical practitioners, we talk about evidence-based practice. There is unfortunately no clear evidence that covert medications or coercive treatments actually improve patients' outcome. A lot of the time, the justifications for all these treatments are rooted in expert consensus. And oftentimes, it's psychiatry who gives these expert recommendations. And one of the arguments we talk is preventing risk to others. Say you have a patient who was previously violent, and then he's well on medications, right? And if he stops the medication, there's a potential risk of violence, for example. The violence hasn't occurred. So how do you then decide that this potential risk of violence can justify the use of covert medications or coercive treatments? And more importantly, whose responsibility is it to make that decision? Is it psychiatry only? Or is it a judge? Or is it a family member? Yeah. Okay, so that's my preamble. It's a very long preamble, I apologize. Yeah. And that's the real reason why I brought my coffee, not because I'm afraid of covert medication. It's just coffee, apologies. Okay, let's get the law out of the way first, okay? Informed consent. Informed consent, I'm sure all of you are very familiar with this concept. It is grounded in the principle of autonomy, that the person knows exactly what is best for him. If a person has capacity, refuses treatment, it is completely unlawful to administer treatment, coercive, covert, otherwise, okay? It can be, in the worst case scenario, this is criminal battery, okay? We talked about best interest already. And case law in the United Kingdom says that not only is it lawful for doctors on the ground of necessity to operate on or give medical treatments to adults without capacity, but it's the common law duty of doctors to give this treatment. All right? Dr. Giles already alluded, and all of the other colleagues also alluded to the Mental Health Care and Treatment Act. Incidentally, if you read the wording, the word treatment is, for me, it's quite vague. It doesn't say, is it coercive treatment? Is it covert treatment? Is it electroconvulsive treatment? It's just quite vague. So it's quite open to a lot of debate and interpretation. So obviously, when we, psychiatrists or other doctors, prescribe treatment, it is a form of medical paternalism, as it were. There is a risk, obviously, of abuse of power, and there's a risk, obviously, that we institute treatments that may not be in the patient's best interest. Now, interestingly enough, we are often asked to assess in the wards patients' mental capacity. Do they have the mental capacity to do this, or do they have the mental capacity not to do that, or what? Medical practitioners are more likely to declare someone incompetent if the person disagrees with them. Really? Okay. Really, okay? And this is where it comes into play. This is where the clinician's own moral values and perspectives kind of come into play. And for example, if a patient don't want to take medicine, and then I say, oh, not competent, okay? We would more likely attribute it to, oh, it's due to his mental illness and his lack of insight, rather than an inherent personal value or wish for him not to take medication. Yeah, okay? In some of the literature, a participant, a qualitative paper, he articulated, it is nearly impossible to persuade the authorities that you don't want to be on treatment because any resistance proves them right. Yeah, okay. All right. We'll talk about the Singapore stance right at the end because essentially that's the short answer to a very long topic. But just some background. In the UK, the NHS Foundation Trust, there are some guidelines to the use of covert medications, all right? How many points are there? There are about 8 points. I'll just zip through them. First thing, got mental capacity or not. Okay, but no mental capacity is not a blanket rule. It doesn't mean no mental capacity means can give covert medication, but you must establish mental capacity. You must understand why the patient don't want to take medicine. And have you tried any other means of improving adherence? Have you tried alternatives? Number 3. Number 4, ensure that the medication is essential. Now, this is tricky, right? Because patients are not just on one medication. They've got psychiatric medications, they've got blood pressure medications, they've got everything. Am I just justified to give just the psychiatric medication? Should I not give the blood pressure medication? Should I not give that? So that one not very clear. And Dr. Giles also alluded to talking to the caregivers. So that's the best interest part of the meeting. Number 6, the administration plan. How to administer the medication. This administration plan is surprisingly quite an interesting part, which few people really think about, okay? And I will tell you why it's interesting. First and foremost, medications got side effects. Okay, you give vitamin A, suddenly cannot move. And okay, the patient, why this vitamin cannot move? How are you going to explain that? So number 1, side effects. Number two, not all medications can be crushed or, mashed up. Sometimes it's even dangerous to crush a medication that's not supposed to be crushed. You might end up doing more harm. And I'd like to share this story. I had an elderly patient, okay? She's got a bit of cognitive impairment. She doesn't want to take her medications, okay? And this includes a heart medication, okay? The heart medication in question is digoxin. It helps to regulate the heart rhythm, otherwise she gets a stroke. So the problem with digoxin is it is blue. So the very intelligent helper, she takes the blue pill, she meshes up the pill, and she sprinkles it over the rice. So guess what? The rice turned blue. So this patient tells my nurse, "Nurse, my rice is blue. Why is my rice blue?" So we just look at her very sheepish. Oh, I don't know. We'll check with the helper, something like that. So this is something we don't think about, the practical things, yeah. And obviously there's the taste and everything that you have to be a little bit careful. Now, obviously you have to document these things properly, because if it's not documented, then the next person who takes over the care won't know what's been going on. And of course, regular review to make sure that, the patient still requires the medication. Okay. Sorry, yeah? Apologies. Drink. All right, next. Okay, we've taken away the law already, so let's look a bit at the ethics of this whole topic. Just to keep in mind, doesn't mean that you are legally allowed to give covert medication means it's ethically allowed, and vice versa, all right? So, when we talk about covert administration of medication, we talk about autonomy as well. What if the patient is non-autonomous, but has some level of decision-making capacity. The problem, as Dr. Giles alluded to, he alluded to the concept of fluctuating capacity. A lot of my patients are elderly, and many of them have some form of dementia or cognitive impairment. I find that they can almost understand, but cannot really fully understand. So they're almost there, a lot of them. And that's when it gets really tricky, when they're almost there. And then obviously the capacity does fluctuate from day to day or from time to time, depending on the situation as well. So it becomes a bit less clear. Now, and someone actually says that covert medication is not just coercive treatment, it is coercive treatment at its most sinister. Because you're not just jabbing the patient, you're hiding it behind this facade of compliance, and then you're doing something against his will. So it's actually quite sinister and quite deceptive if you think about it. Now, we talked about least restrictive options previously in the earlier talk by Dr. Giles. What is the least restrictive option? Consider this, a person, very, very psychotic, very unwell, and then you restrain him for hours, and then he's being jabbed against his will. Situation 1. Situation 2, we surreptitiously give him medication, he calms down, he can talk to you nicely, he engages with treatment. Which is more degrading, which is more inhumane, and which is least restrictive of the person's liberty and dignity? And obviously the third option is if you don't do anything at all, the condition will just deteriorate. Then his dignity, how? Isn't that worse? So not very clear. And in some of the literature, they also interview participants who have undergone some form of coercive treatment. Guess what? They felt fearful, they felt angry, they felt helpless. A lot of them felt very traumatized, and this is something that's really very tricky because a lot of our mental health patients, in their early lives, they have experienced some form of trauma already. And then you are deliberately in what is supposed to be a safe therapeutic space, you're letting them re-experience the trauma that they are trying very hard to overcome or to even avoid. And obviously there is a negative impact on the therapeutic relationship. Many of my patients, after they get admitted, then they get discharged, they come up to tell me, they describe how, not that the treatment was bad or that the hospital was terrible or anything, that was not the point, but they just felt helpless, detained against their will. But interestingly enough, this just happened this morning. I was running a clinic this morning, so there was this patient of mine, a 64-year-old man. He had been admitted to the hospital, correct? He was psychotic. And they had coercively restrained him because of his behaviors. And then he was describing to me how traumatic and how difficult it was. But then he told me, after the whole thing happened, the nurse sat me down and the nurse talked to me and explained to me why they had to do it. So, and then it made me think. It's like after you scold a child, and then after that you have a timeout, and then you explain to the child what has happened. So I think, whilst coercive treatment has its problems, what you do after you administer the covert medications or the coercive treatment is probably more important to help rebuild that relationship or that trust. We mentioned trust. Trust is fundamental to that therapeutic relationship, okay? If you don't trust your doctor, you are not likely to go and see him for any treatment. Conversely, if you trust your doctor, everything he tells you, you will also accept, more likely to accept, okay? And patients report that aside from medications, sometimes a trusting, safe relationship where they feel heard and validated is as important, if not more important, to their recovery. So it's something to think about. And of course, and this has happened to me before, what happens if after all is said and done, you covertly administer medication, the patient finds out that you have been covertly administered medications? This actually happened. So I have another elderly lady, so she's got dementia and she hallucinates, right? So she attends the day center in the mornings and in the afternoon. I had been prescribing her with antipsychotic medications so she doesn't hallucinate. And then because when she hallucinates, she starts to talk funny things, she starts to get very agitated, etc. The medication is supposed to help her to remain calm. Now, we didn't covertly administer the medication in the traditional definition of the word, not in the disguised form, but we told her that 是补脑, which is vitamin for the brain. Okay? Oh yeah, okay, good, vitamin for the brain. Okay, so she was so she was compliant with the pills, We do this a lot in dementia, by the way. We call it compassionate deception. Okay, yeah. So lo and behold, she's at day center. So the staff administers the afternoon dose of the antipsychotic. So the staff was new. So she sees the risperidone. Auntie, this was xiao lang, and that's a crazy medicine. What you take? So, yeah, not a very pleasant experience. But this is true. I'm not making this up. What happens if patients actually find out, And let's say the patient gets better, do you retrospectively tell them actually, when you were in hospital, there was a period of time, your ice cream wasn't really ice cream, it was something else in the ice cream that was supposed to be good for you. Is there any guidance as to what we should, Yeah. So I think the question at the back of our minds is, what is your end goal? What is your final goal, right? Is it just to prevent relapse? Is it just to make sure they stick to treatment? Or is it to allow them to lead a fulfilling life, a self-determined life with some dignity? Okay? All right. I feel just a little bit more to go. Right? Okay. Families and caregivers. Families and caregivers are quite important. Okay. It's a very covert medication, complex ethically. So as with all such issues, there's no simple answer, okay, that fits every such patient. It's very good that there is this discussion here where we talk about these ethical principles. My belief is that the ethical principles, the ethical discussions should happen on the ground with the family, and then, because that's where it actually happens. That earlier case, we gave the antipsychotic to that old lady because she was hallucinating. Now, clearly, we should not administer medications covertly just because of convenience, right? But I feel this is also a little bit tricky. How do you define convenience and inconvenience? Now, I'm not going to stigmatize patients with dementia, but for those of you who have ever cared for a person with very severe behavioral symptoms, you would know that it's not just a matter of convenience. Sometimes these patients, some of my patients, I have one patient, I got very funny stories. I got one patient take knife. I got one patient want to set fire to the house. I got one patient keep playing with her feces. The other one keeps running out of the house. So to say that for the convenience of the carer, we give the medication, it's not just inconvenient to take care of patients with all these problems, but it's really, really challenging. It's really a struggle for those of you who actually have persons with dementia in your own personal lives. My belief is, my mantra is happy carer, happy patients. Yeah. So if the caregiver is very stressed, desperate, angry, frustrated, the person who actually suffers ultimately is the patient. So how do we balance that? How do we balance that? Now that having been said, obviously there are caregivers who don't always have the best interest of the patients at heart, right? And if you think about it, it's quite ironic because the caregivers, the families are the ones the patient is supposed to trust. The patient trusts the most. But yet, it is them who are responsible for the deception. Okay, there's also some of the literature also suggests, right, it also really depends on which legislation, which countries you practice in, because in some of the bigger countries where a lot of rural kind of areas, the community mental health is not so developed, right? The families are the main ones responsible for the care of the patient, right? So there is no nurse that can go there and help to convince the patient to take the medicine. So ultimately, it is the caregiver who gets to decide actually whether or not how to administer the medication, right? So I think the setting is also important, and when we talk about this issue. Okay, just a few more bits to iron out. Okay, collectivism, or the good of the society as a whole. This is the exact opposite of individualism, okay? How does one balance the notion of individual rights versus the good of the society, of the family unit? Okay? Shouldn't there be an argument also for protecting the interests of the family? Shouldn't there be an argument also that there should be a mutual regard for all the autonomies of the various family unit? A person is not just an individual. A person is a relational being. He lives in connection with other people. Every one of us, we have a duty not just to ourselves, but also to respect others and not to harm them. If coercive treatments or covert medications can enhance our own responsibility towards others, right, then is that a justification for the use of such treatments? All right. Okay, cool. I have one slide. Okay, but it's very small. Okay, so this is the short answer to the very long question, which is, what does the Ministry of Health say? What's practiced in Singapore? This is 2019. This is the MOH directive on administration of medications. Okay, a little bit of background of what happened in IMH. Before COVID, 2-3 years before COVID, we did set up a committee to talk about covert administration of medications, because we felt that we were dealing with a very specialized group of patients. We brought this up to the higher levels, but I think the stand is pretty clear that in Singapore, at the very least, covert medications are still frowned upon and not allowed, to say the least. Okay? The reason why I brought up this slide is because, how do I do this? Okay, look at it. So essentially, if the person is under the Mental Health Care and Treatment Act, you can administer medication. So it's basically the bottom part, medication may be administered. It does not say whether it's coercive, it does not say whether it's covert. Okay? The contrary, if the person got capacity, is autonomous, you cannot administer medication in whatever way, shape, or form. Okay? Then there's the gray area, okay? Not on Mental Health Capacity Treatment Act, not on Mental Health Care and Treatment Act, but then no capacity, needs the medicines in the best interest, they go to the medicines may be administered. So based on this guideline, it's also not clear for that group of patients, can give covertly or not, can give coercively or not, also not very clear, right? All right, so in summary, covert medications or covert administration of medications should be evaluated on a case-by-case basis, okay? A lot of elements to think about: ethical, legal, and we need to balance all these elements, and also taking into account the feedback from the patient and the caregivers. But more importantly, right, is to keep in view the longer, broader term of how whatever we do will affect the care and the personhood of the patient, and how eventually our goal should be to help the patient regain autonomy and to rebuild identity. I'll leave you with one last quote. This is by Aaron Levine. He's the author and past president of the Washington, D.C. Science Writers Association. He said something really poignant, which says that rather than resorting to deception, maybe accepting limits may be the greater part of wisdom. So with that, I will end my talk on covert medication. Thank you very much, everybody.